Good morning, good afternoon, good evening, and good night. This is the nature of the IAPD and an example of the complexity of running an international organization online, and indeed offline as well. We are very pleased to have hosted such a successful event. Our AMC Paragon through Daphne and Lorraine have been working around the clock behind the scenes to ensure all goes well. IAPD's board of directors and committee members have devoted hours and indeed days of their time in organization and in reviewing the hundreds of abstracts that have been submitted. Thank you. You, our members, have been active with Q&As, chats, meeting rooms, and it shows the strength of our international association, our IAPD family. We have many more surprises to come throughout the year 2021. So please make sure to renew your membership and stay a part of this wonderful organization. Our next speaker, Professor Richard Widmer, received his master's degree in pediatric dentistry from the University of Melbourne. The majority of his pediatric clinical practice over the last 40 years has been at the Westmead Center for Oral Health and the Children's Hospital at Westmead. He holds the position of Assistant Clinical Professor in Pediatric Dentistry at the University of Sydney and Head of the Dental Department at the Children's Hospital at Westmead. He is a very active clinician and lecturer, presenting to students and graduates in all branches of the health sciences, both locally and internationally. Over the years, he has held a number of positions with his specialty, pediatric dentistry, and he has been the president of the International Association of Pediatric Dentistry, the Australian Academy of Pediatric Dentistry, and the Australian and New Zealand Society of Pediatric Dentistry. Professor Widmer co-edited both the very popular Handbook of Pediatric Dentistry, now at its 4th edition and in 7 languages. Richard is a true visionary. He has the unique ability to foresee the future. I am confident that his presentation will be both informative and mind-opening. Proof of his insight was seen by all at IAPD's 50th anniversary International Congress, which was held in Cancun over a year ago, way before the onset of the pandemic and the worldwide use of Zoom. Richard addressed the audience, and I share with you a brief cut of his greeting.
Welcome to Cancun. My name is Richard Widmer. I'm one of the former IAPD presidents from some time ago now. So have a great time in Cancun and look forward to seeing many old friends here. See you later.
So, without any further ado, I call upon Richard to start his lecture, A Child's Face, Looking versus Seeing.
Thank you, Ari. I will share my screen. Good afternoon, everybody. And so today, A Child's Face, Looking versus Seeing. And it's a pleasure to be here. And I want to thank the committee for inviting me, and it's a great honor. And it's 5 p.m. here in beautiful Sydney on a Tuesday afternoon, and I hope wherever you are around the world, from Tampere to Auckland, or from Toronto to Joburg, you're safe and well at this time. So today I'd like to talk about the recognition and relevance of some important clinical presentations in our infants and tweens and adolescents. And I'd like to thank the many pediatric colleagues that I've worked with over the years, registrars and trainees as well, and all of them in their own way have contributed to this presentation today. So I'd like to thank them at the outset. So historically, what do we have? Well, from the first cave paintings to the present, most cultures have endorsed the value of youth and beauty and associate distortions of human form with evil and terror. We can go back to the stone tablets 2000 BC for depictions of this, or the ancient Greeks had their own ideas, particularly in the way they looked at medicine. In the 18th century Europe, there were numerous laws in many countries to prevent adults and children with special needs and obvious syndromes from mixing in the public and transferring their evil spirits. And in the 21st century, of course, now we have an obsession with youth and beauty that's taken on the world, no doubt, through social media. We look at the Greeks, and they believe there are 4 fundamental types of temperament. And you could pick this from a person's face, and that helped in the way you treated them and the medicine you provided. And you were sanguine or phlegmatic or choleric or melancholic, and so your treatment was meted out. And these ideas have persisted in languages, in many languages throughout the world today. These ideas have picked up from looking at people and judging them. And this was called physiognomy. In the 18th century, they called it, they labeled it as physiognomy, the ability of that art to discern a person's character from the features of their face. And I guess we all still do that to some extent today. But can we put some science and some order into this? What do we recognize inherently? Now, we're all good at the orofacial and dental patterns. Dental, overjet, overbite, midlines. We notice these things without thinking. Skeletal patterns, of course. And we also notice facial symmetry. And we make a comment on gender without even thinking about it. And hair, and where that is placed and where it isn't. And especially eye contact. And how important is that when we're working and looking at someone, of course, with behavior. The idea of facial symmetry, it's always struck me that we look at people for evenness. And for many years, I've worn different colored shoes. And people would always notice that. But if I wore normal shoes, it wasn't noticed. And I think that we look at individuals and we scan each other for evenness. And when you notice something different, you pick it up. And we do this inherently. So we look at these young guys and we made a decision already. Are they boys? Are they girls? Are they special or not? Have any other interesting things about them? And we've already looked at their ears or their mouth or their nose and made some inherent decisions. Or we look at a young person like this. And we also remember that we're looking at physical things. We're also looking at mental health as well. We look at children. This young lady has a face that really is a measure of physiognomy. By her background, it's difficult and it's not easy. And that's written large on her face. Or this young guy, you see, he looks a bit different. Is he a bit special? He's got some scratches on him as he runs around, and he's no distinct philtrum. His vermilion border in the maxilla is rolled in and under. And is there anything about him that's different, and what are we judging? So what are the measurements that we can use? And we can look at eyes, we can look at the width of the mouth, and look at the nasal dimensions, the nasolabial angles, we look at the ear position. Of course, we measure height and weight and head circumference. And we look at developmental levels, which are crucial. And I, for one, relied on speech pathologists a lot to give me an assessment of a child. Are they at the appropriate development level, or are they not? Is their language, particularly the language behind? Are they have cognition and dictionary and vocabulary that you would expect? But let's have a look at what we can see with the person here. So we can do facial thirds, hairline to bridge of the nose, bridge of the nose, tip of the nose to the chin. And therefore we can describe someone in relative terms who has either a mid-face hyperplasia or a relative longer lower face, doliocephalic or mesocephalic or brachycephalic face. We can measure the inner canthal distances and go to a norm that's for Caucasian or different racial backgrounds. We can measure interpupillary distances, and we get an idea of hypertelorism or hypotelorism, wide apart or close set eyes. We can look at the distribution of the eyebrows and hair and eyelashes. We can look at the inner canthus lining up with the alar of the nose for evenness, and the mid-pupillary line lining up with the edge of the oral commissures, and get some idea of evenness in the face that we look at. And we can measure also the width of the nares and so forth, and get an idea to a norm of a particular facial appearance. So then we might find someone who has a relative mid-face hyperplasia, mouth open, tongue forward posture, and no surprise that the tonsils are large and the airway is compromised. But in profile, we also need to describe what we're looking at as well. And ear position is very important, hair distribution. And if we extend the ocular plane back to the superior attachment, back in that line there, the superior attachment of the eye, of the ear, should be on that line, and the ear in about a 10% position to that line when you attach draw a line from superior inferior attachment to the ear. And so we can develop an idea of ears. Are they rotated? Are they low set? And of course that goes with some other syndromic backgrounds or not. And embryologically, where are ears at certain stages in the embryo? And of course the pinna needs to be looked at, and malformations of the pinna can also be diagnostic and helpful with syndrome diagnosis. We can look further at various aesthetic planes. The Ricketts E plane was one of the first ones, where the nose to chin distance and where the lips sat in that line, and what sort of profile we would expect to have with a typical profile. Or we can look at the nasolabial angles, that usually acute. We can then measure other profiles from the glabella to the base of the nose and so forth. There's a number of these aesthetic plane measurements that we make judgments on in helping decide treatments, particularly, of course, with orthodontics. So you can, as you mentioned, have an ear that may be low set or rotated, the pinna rolled, the lobe is a little bit different as part of a syndromic background, or we can have an ear that is completely malformed and the pinna is actually not there at all. And so a description of the ear becomes very important. And in profile, we talked about the nasolabial angle. If that goes from acute to obtuse and gives you a relative prognathism, we're making some ideas about what dentition we expect to find, what lack of support for the upper lip in the anterior maxilla that is there. It's one thing to remember when we're talking about children and to children and with families, it's important not to alienate or intimidate by the language that we use, which we can, and often just simple dental language, can be like eruption of teeth or something, can be frightening to a child. What else erupts? But volcanoes, for example. So that sort of language becomes crucial, and it's very important that our language is appropriate, and that sometimes we don't talk about the child things. We talk to the family separately or the parents separately. And sometimes you might ask questions about a history, and sometimes the family don't know the history. Maybe the child's been adopted, or et cetera, et cetera. So you have to have you'll be very empathetic about the history, discussing it, and just what you say and whom you say it to when you are looking for signs and symptoms that may be helpful for the child. And always remember, some of the things you may notice, it might be unusual hairline or wide apart eyes. That may just be the family, and nothing a health concern at all. So have our empathy out when we're talking about and to children. So let's look at growth. Now, growth is usually head to tail. When the child is born, the brain is about 60% of its adult size. The next few years it grows. By about age 5 to 6, it gets to full size. It's a variable rate in growth, and it's symmetrical. We just have to look at babies to see it in that head to tail growth. The 1 to 2 year old child, the 70% of the cortex is focused on the orofacial region. The world's experienced through there. You just look at the little ones and everything goes into their mouth. You try and examine them and they want to see what your finger looks like and feels like and chomp on it and so forth. The orofacial region is front and center, literally, to the growth of that child. As the individual gets bigger, that slowly heads in the caudal direction. The variable rate, it's important that children do grow at different rates and different velocities, but that they continue to grow, that they don't fall off on your height and weight charts and actually plateau and fail to keep adding appropriate height and weight. And of course, growth is usually symmetrical, although we're not really symmetrical completely as individuals, but symmetry is important. So this little guy here, the thing about him is that he will have even growth, and you look at him in 3 or 4 or 5 years' time and you realize it's the same child. And sometimes people say to you, wow, or you say yourself as a clinician, wow, they've changed. And it's a bit like saying, well, of course they have, you expect them to. But what you're really saying is that the proportions, you recognize that child, despite the passage of time, but the proportions are the things that you remember, and they've been maintained and growth has been consistent. Sometimes you work at a child and you notice, and you maybe sitting a child in the dental chair and you look and you might notice things are different when you're looking from a different view. And this is slightly where the head shape is a bit like a trapezium with plagiocephaly. And how important is that? And does it represent a craniosynostosis that needs to be worried about, and so forth? And these things you notice, this is very subtle, but it's a metopic ridge in the midline here. And again, that's very important that is a side-on view of that metopic ridge, and it's important in diagnosing if there's early fusion of those sutures there, which is a problem if it is that situation. But you can just notice that subtle groove on the forehead. Sometimes there's a facial asymmetry that's not obvious until you highlight it by just placing something like a piece of cardboard there to highlight the slight differences between the right and left side here for this young person. And you may not notice that initially, but you do when you place that there. Or similarly, you might have a young guy with the facial asymmetry and you notice it and you think, well, I'll investigate that. And it turns out that, in fact, he's a trumpet player and he often gets, not often, but he does get air in his parotid gland, and he's had this happen before, and it's nothing that stays there. Another measure you can do is the handspan, and you'll be familiar, of course, with Marfan syndrome and the long hands and long fingers, long arm length and the long spindly fingers. And before puberty, the handspan should be 10% less than height, but after puberty, handspan is equal to or greater than height. But in certain situations, it's significantly greater. And that's something that you can measure and be aware of and appropriately refer. So let's have a look at some children's faces. This little guy comes in and you notice he's got a cute button nose there and nice cheeks. But there's also an interesting thing with his upper lip, and you notice his lower lip is a little different on one side compared to the other. And it's just a different amount of vermilion, mucosa of vermilion borderline there. His dentition looks a little like this. Well, he has a pacifier sitting here, but the midlines are quite out now, and there's a flattening off of this area of the lower arch. This is a little one who has what's called the asymmetric crying face, and it's called that because often it's when the child starts crying in the first few weeks, months of life, the family might notice that the smile, the cry line is crooked, or the smile line is crooked, and we'll ask you about it. And the interesting thing about the asymmetric crying face, where the depressor anguli oris is either absent or poorly innervated, or a combination of those, is the association with other issues, particularly cardiac problems. And the veracity of this sign is often goes in and out with people, but it's certainly a very important sign to notice and get appropriate referral little guy, particularly to get check cardiac and renal issues, and sometimes digit anomalies, the asymmetric crying face. Some other little ones that appear with a very subtle difference, and the family have come in and have noticed that the cheeks are a little bit different either side. There's getting to be a little bit difference in the smile lines and so forth. And when she opens her mouth, she's deviating to the left. And it transpires that she fell 6 months earlier when she got out of the bath and was running around like kiddies do and hit her chin. And she's obviously damaged her left, in fact, she broke her left condylar head, and it wasn't noticed, and they didn't seek much care at the time. And then subsequently, the family have come in as the facial changes become more obvious, particularly the midline you can see here, but her facial contours are just changing subtly. Similarly for this young lady, who has just a slight swelling here compared to the other side, she's had this for about 18 months, and it transpires that she's damaged her parotid duct opening, probably an accidental chew of some description, has a little stone forming and has got a backup in the gland, some stasis in the gland with a salivary flow, and is getting a recurrent swelling there, often low grade. Again, a subtle presentation. This little guy fell over at daycare and was thought to have a bit of a bruise, and family didn't worry too much about it. But he fell a few weeks later, and the bruise and the swelling didn't go away. And He presented to our hospital where the emergency team thought they'd investigate. And this is the intraoral view. And he has a large central giant cell, peripheral giant cell lesion there that manifests after the first fall, became obvious. And the family hadn't noticed that slight swelling, which is actually more than slight swelling. Some of the physicians talk about a myopathic presentation for a little one and having a tapering face with a prominent forehead and a tinting of the mouth opening, of the oral opening, and calling this a myopathic face, and often having a significant dimple in the philtrum. I'm sure in many countries around the world, but particularly ours, where the sun in the summertime is a big issue, we're very careful to notice these conditions and make recommendations. It's important. This little, I guess, mole, if you like, is unusual to change and become difficult in a child, but it's important to record it and be able to know if it has changed or not. Similarly, this young person with a very Celtic makeup has already had some lentigos on his lower lip, and there's several of them where he's had some burns, and he's got to have a lot of advice on keeping out of the sun. Sometimes families come to you with an unusual issue, and this young guy, when he chews something like an apple or a pineapple that is a bit tart, he gets a red swoosh on his cheek, a Nike-type swoosh. And this is a little guy who was born with forceps delivery. And this anomaly is called Frey's anomaly, or auriculotemporal syndrome. And there's been a crushing of the auriculotemporal nerve with the forceps delivery. And when the injuries healed, there's been a mixing up of sympathetic and parasympathetic fibers, and he gets a gustatory sweating now. So when he tastes something, he gets a sympathetic response in his cheeks, and a dilatation of blood vessels, and gets the red swoosh there. And it can get quite warm and discomforting for some children, but other issues when you're older can cause a damage to parotid glands and things. But that's a little example of a child who's had Frey's anomaly. Of course, this young lady on the left is a terrific young lady, and the first thing we notice is that the vermilion border of her maxilla is rolled in and under, and she has very limited showing of that upper lip. So you're wondering just what the teeth are like there, and the lower lip has fallen in and under, and she has a bit of salivary flow and irritates her mental fold. She's never had a haircut, sparse eyebrows and eyelashes, and her toenails and fingernails don't cut. We all know and recognize this as ectodermal dysplasia. As you can see, the classic missing lower incisors. But fascinating too, the salivary glands are of a mixed bag. The parotid glands are ectodermal, but the submandibular and sublingual are endodermal. And they do get a bit mixed with other tissue in the long run embryologically, but you can see here the salivary flow is poor, ropey, bubbly saliva, which makes you very anxious about caries and so forth. So ectodermal dysplasia. This young lady is a bit of a surprise when she comes to see you, and she is reluctant to open her mouth, and in fact I ask her to open her mouth and she can't. And it appears that at a young age she's had either trauma to the condylar heads and they're fused on both sides, or it's an inherited issue. And you can see the antigonial notching here telling us that the ramus and the body are growing differently. And this is her occlusion on the day when I did politely suggest if she could open, I could have a look. And that's all one could see. I mean, it brings up so many fascinating issues about growth and eruption of teeth and what would happen if she was unwell and vomiting and all sorts of things. But a most unusual presentation. And sometimes looking at a young guy like this, you're busy talking to the family and noticing things. And it wasn't until later that I looked at where his hands were and how he was able to put his elbows back and reverse them with his background, with his medical background. So skin. Let's have a look at some of the presentations with skin. Now, a lot of kids come in with bruises on their knees. They seem to jump on, play on rocks and bang their knees and run around. But bruising on the arms is a different story. And you notice that arm when the jumper's pulled up. And this is a young man with von Willebrand's disease, and he's got bruising in a different place. This young man, bruising all over, but on the arms is not a usual place. This young man here has got lots of what look like infected areas, and these are mosquito bites, but he has an immune response that needs a regular topping up. And again, we notice that when he's in summertime, his shirt's off, and you're thinking, well, will I time my gentle treatment to when his immune system is performing better? We're all familiar with facial hemangiomas, Sturge-Weber-like syndromes, and we expect to investigate the maxilla and so forth for areas that might bleed with tooth eruption or extraction if they're necessary. But sometimes the petechiae and the facial problems can be a lot more subtle. And here's a young guy with just a couple of facial petechiae, a couple of areas of capillary excess in the shoulder. And here he is looking at his mouth and having a significant presentation in his mouth. And initially, I'll be honest with you, I didn't notice that. And I'm examining him, and his mother, we're doing a knee to knee, and his mother says to me, "What's that?" And she got a better look at it from her angle, and we had a good look in there as well. And of course, the concerns here are with eruption and growth and what might happen, and the appropriate investigations have to include the oral and facial region. Similarly, a youngster with some unusual and consistent little infections on the skin and troubles generally with his skin, and presents with a swollen, bleeding gingiva, spontaneously bleeding gingiva. And he's a classic presentation of a boy with a neutrophil function defect. And the soft tissues are so instructive, particularly in little ones, for the early presentation of neutrophil function defects. And in this case, he was involved in the immunological team, and we monitor the oral health, and he goes on long-term Bactrim as a start as they consider other options. The skin can be quite significant, as is an example of Papillon-Lefebvre syndrome. Excuse my poor French. Papillon-Lefebvre syndrome. And of course, this goes hand in glove with oral manifestations. And here's a reasonably mild form. The teeth are loose. There's deposits. There's quite a strong halitosis. And there's a child with the same condition, with certainly some consanguinity involved in this particular, in both cases, but more significant this one on the right. And you can see that the advanced periodontal disease and the concerns with the loss of teeth and what to do in managing this condition. And certainly from when we first met these guys, management has changed significantly, and the recognition of the neutrophil function defect that was made with this family here has changed things significantly. Just a small petechiae from a bump on the lip, but no, this was a youngster, actually a 12-year-old presenting with idiopathic thrombocytopenia purpura, ITP, and that little bleed on the lip that was typical. And on the buccal mucosa, there was also presentations of these petechiae. First time that we'd seen them, and the young lady come in for extractions that day, and the dental officer observed, and I was wondering about, what is that? What's concerning that? And we took it further, and likely didn't proceed with anything invasive on that day. Just a little bit of variation. A youngster who turned up with a very significant infection and came in with his school teacher, and there's an incantation here written on the skin, the cheek, to get rid of the evil humus. And we go back to one of the first slides. We talked about the body having balance of the four humus. The vital humus, as the Greeks and the Romans thought, and some of these beliefs persist today in certain cultures. And this was an incantation, apparently, to get rid of the evil humus that were affecting the boy, written by his grandfather, who didn't have faith in the Western medicine he was exposed to. Hands and skin, again, are very important to look at. So this young man highlights the issue that we can face as clinicians, where we can be quite important in tying together loose ends. And this young man has got a denture in. The dentition was, not in really good shape. His gingiva looked very almost raspberry-like and small red bulbous areas. And he has a background of Galt's syndrome and the subdermal focal hypoplasia. And he'd been to different places and moved around a lot. And no one had ever really put a handle on his background conditions. And it wasn't until we got a few reports in different places and put them together with the geneticist at our hospital office that they made all the right connections and the appropriate advice and follow-up was given to the patient, to the owner and family. So never underestimate your role in providing a source of bringing together lots of different things that the family may not have had connected elsewhere. The malar flush and the red lips of someone whose cardiac system is struggling a little bit. And you look at her hands and you'll notice they'll be warm to touch. It's quite important to feel the hands, and like the papillon lefevre children before, they're very rough skin. The previous boy with the missing parts of his hand, and the young lady have quite warm fingers, hands, and fingernails are covered with nail polish, so it's hard to see anything in the nail beds, but it'll be there. Similarly, it's important, this young man with a short stature history has an interesting variation of his hand with a very short little finger. And hands are fascinating with the variation in finger length and how diagnostic that can be with the shape and the clinodactyly, the small bent little finger here. In other situations, you can have a long finger-like thumb, and there's many variations. But so looking at the fingers, it gives you a great lot of information. You can see this little guy is biting himself and damaging himself, and it brings up the question why and what's his background. And these are the finger-like, the pads of a young person with Kupietzky syndrome, and you can see some clubbing of the fingernails here and these broad fingertip pads which are typical in Kupietzky syndrome. It's interesting just stopping to think a little bit about hands. There's a lot of discussion on the relationship of the ring finger and index finger. Most people have a slightly longer ring finger than an index finger. And the length of the fingers, interestingly, is apparently set in utero and appears to be related to the level of testosterone. So you can see where this goes. There's a lot of discussion on sexuality, disease risk, sports ability, risk-taking, all based on the finger length of the index and the ring finger and those relationships. The veracity of those relationships is always questioned, but it's certainly a fascinating area of interest. And I always look at little one's hands and compare the ring and the index finger. And I hope you're all doing that right now. Eyes. Now, eyes are fascinating. It's the most interesting part of, I think we've been working with kids, one of the most interesting parts. So we've all seen the blue sclerae of a child with the melanogenesis imperfecta. Now, at birth, about maybe 10–15% of children can have blue sclerae, but that's related to the fact that the sclerae is very thin and the underlying uvea is showing through. And it takes about a year for the color of the eyes to come in too. Most eyes, I think, are brown is the dominant eye color around the world, and it takes a while for those colors to come in. But certainly the blue sclerae can be there and not be osteogenesis imperfecta, or it can be just a normal variation of the sclerae till they get the normal color settled. Fascinating heterochromia, different colored eyes, and there's a bit of a syndromic background to this as well. And it can go with a syndrome of autosomal dominant hearing loss with a white fleck in the hair, and they're called Waardenburg syndrome. Heterochromia is fascinating, and there are a number of people have this with no other syndrome association, others have it. And you'll all be familiar with a famous rock star who had different colored eyes. I'll leave it to you to remember if you can. Eyes can be wide apart on a norm or close together. So this young person here has quite wide apart eyes, hypotelorism, broad nasal base here, and her ears are a little bit rotated and low set. But is this her family? Does she look like the rest of her family, or is it syndromic, or is it not? And she did look like other members of her family, but had a background of Kupietzky syndrome, and the hypotelorism was part of that. And remember, in discussing these things about individuals and talking about them, it's not a judgment on the individual, it's just putting in context to help you as a clinician to find the right treatments, to steer people in the right direction without any other judgment being involved on the family or individual. And it's important to remember that. This young lady on the right here has quite definite frontal prominence and is more hypothalamic, eyes close together, and mid-face hyperplasia, and multiple supernumerary teeth, hypoplastic clavicles, and can oppose her shoulder blades, cleidocranial dysplasia that will often present to us as clinicians with the slow exfoliation of the primary teeth in particular. But her characteristic facial appearance is a great help in getting that diagnosis earlier. This young man has hypotelorism. His eye sockets are downsloping, the palpable fissures. He has a square to tapering face here. And of course, he's got an interesting single solitary central incisor. And here he is as an infant, about 8 months. So the single central median maxillary incisor syndrome is a crucial one to remember because of its association with midline discrepancies, but in particular, growth hormone deficiency. And just to make this point, this is a lady of 40 years of age who, when I was looking after her daughter, said to me, you know, I only had one front tooth as a young girl. Really? You sure about that? And people sometimes get things wrong, and it may have been a supernumerary taken out or something like that. Anyway, tracking back and getting some history, and she certainly had the syndrome. And here she's had orthodontics done and some prosthetics done, and has had a pretty reasonable result, and she was very happy with it. And I think it's a very good result, but she had no idea of the other issues in her life that were related to the missing tooth, and significant midline discrepancies for her that were causing her significant personal and medical problems. And we were able to steer her to the right people, and made a difference to her life to recognize that at 40 years of age. And she'd had medical and dental care, and no one had appreciated, oh, that's just one front tooth, so be it. Eyes, again, fascinating. This is a coloboma or keyhole. It may or may not be significant for sight, but it's certainly worth pursuing and making appropriate referral. Now, you can be the first person to notice a slightly turned eye, and I have this experience in my own family. And one of our kids, when they're quite young, had a slightly turned eye, but we never noticed it. Till my neighbour said to me, made a comment one day about it, and I went home and had a look, and so we had to do something else, just in certain circumstances. The point being, often as family members, you don't notice things because you're living with people. Are you living with that? You notice it, not noticing the speech not progressing, you're still interpreting speech, and all those things could be missed. And you, as a clinician, peripheral to the family, are in a very interesting position to make some sensible and reasonable appreciation of some of these differences, which can be important. Similarly, it can be a similar issue with another eye problem, with that inability to raise the eye. And there's obviously a number of these things. The important thing is to notice them and make appropriate referrals. This young lady was very interesting in that she actually didn't have sight in her right eye, but it wasn't noticed till she was about 4 or 5 years of age. She didn't tell anybody that she couldn't see out of that eye. She just learned to turn her head to get a better view, and had an early consultation as a 2-year-old about something with her eye, and it was never followed up. So again, it makes an important point as clinicians, ask about hearing. and ask the family, ask about sight. Can you see things? And you never know what's been missed. Again, you have a dilation of the pupil on one side, not the other. And what's this caused by? And this is in fact a follow-up to chemotherapy and damage to the cervical chain with chemotherapy for cancer, and that eye doesn't accommodate nearly as well. Congenital ptosis. Again, it's very important to decide, is that new? Has you always had that? As it get worse at the end of the day? And if it's certainly coming out of the blue, you're wondering, is there a reason for that, and needs to be investigated. An unusual reflex called the Marcus gun reflex. And when this little one opens her mouth, her right eye closes. And in other situations, it can be chewing or a suction motion can make the eyelid droop. And it's called the Marcus gun reflex, or the inverse Marcus gun reflex. And it's a fascinating reflex, apparently, with the relationship between pterygoid muscles and levator and the elevating muscle, elevating nerve to the superior muscle of the eye, the nerve to the superior muscle of the eye. And just to trick you a little bit, this little guy is very intent on following what you're doing and showing you a few things, and then he turns away and you notice that one eye doesn't follow. And of course, he's wearing a prosthesis. And those who've worked with kids who've had a prosthesis for a retinoblastoma or something, they often love to pop it out and show you, much to your surprise. Noses. Now, we could spend all day on noses. And I have a thing in my working life where I get the children to push their nose to make the chair work. It's my little thing to give the children control, and they do it at 16, they do it at 2 or 4, but often they still do it. Here she is giving it a really good push, and I couldn't resist taking that photo. So noses. This is a young lady with velocardiofacial syndrome. A bulb is tipped to her nose. She's not well oxygenated, and she has a bifid uvula. Now, sometimes there will be a mid-palatal notch here, but not always. And the bifid uvula can appear de novo and not be syndrome related, but it will manifest in a little one with feeding issues and food out the nose as an infant with feeding, and later on as hypernasal speech if it's not noticed. And it needs to involve the various speech pathologists in particular to assess the nasal flow and to make sure that if any surgery is done to tighten up that the adenoids aren't lost, because often they prevent a lot of excess airflow where this soft palate is called a submucous cleft palate, and it's not functioning as a soft tissue valve. And so it's very complicated when you think about it. The palate has to go up and down with coughing and sneezing and drinking and talking, and it's a very complicated, sophisticated coordination, and that needs to be assessed thoroughly and decisions made if the submucous cleft needs work on it, and can that improve the speech for the person involved. And often it can be in a family that have had the background and has not been realized before till their child is picked up with it. And the important thing about these kids is that they have issues at school with abstract reasoning and learning in mathematics and things, and it makes all the difference to them and their family if at a young age it can be recognized that that they have this medical background, that they get a cardiac check as appropriate, but their speech is improved and issues with learning can be anticipated at school. It makes a big difference. Sometimes the nose, the anterior nasal spine can be absent, and this is called Binder's syndrome, and it flattens the face off you with a philtrum that's not really very well defined, and a bridge of the nose which is reduced, and in profile you can see it gives a pseudoprognathism to this young person with an absent anterior nasal spine. Hair. Now we could spend all day talking about hair, or have someone talk to who knows a lot more of that about me. It is a very fascinating area, and hair is really important in diagnosis, sending hair samples to dermatology and so on, in confirming ectodermal dysplasias and other issues with hair. The distribution of hair, is it racially appropriate? Is it inappropriate? Is it gender appropriate? What age do you expect hair, eyebrows, and excess hair on ears, and so forth. So there's a lot to be learned from observing the distribution of hair and the hair patterns and following through. And this young guy here with Cornelia de Lange syndrome has a very particular hair pattern of cynophorus, which is essentially one eyebrow, is a typical appearance. But hair is very important to pick and notice appropriately. And sometimes it can be associated with, that cynophorus can be associated with gingival overgrowth syndromes and appropriate information provided and care instituted in these situations. One other interesting aspect to remember is that sometimes children and adolescents remove body hair and pull out their own hair, or in this case, remove their eyebrows and the hair. And this is something that's quite significant as far as psychological medicine is concerned, and something that once noticed should be discussed with family and with the appropriate general practitioner or the psych med team to discuss why this is happening. It's quite a significant thing to notice. Trichotillomania is the name. Now the mouth. So I've got this is a primary dentition here to have a quick look at, and I hope you all notice straight up 5-1 and 6-1. Sorry, 5-1 and 5-2. I'm not sure in the North American numbers which that would be. 4 and 5, I think it might be. No, it's true. I'll do the WHO numbering. 5-1 and 5-2 are fused. Sometimes I didn't notice that straight up. I'll be honest with you. I was too busy looking and not seeing. Hyperplastic second primary molars. We've heard about quite a bit about that this conference. But one fascinating thing is the publications that equate these hypermineralized, hyperplastic teeth with early signs of celiac disease. And it's something to tuck away in your memory bank when particularly just an isolated tooth or maybe only two turn up. Is there something else going on? Now, why are teeth slightly separated here? And I've always fascinated, I'm thinking, well, now why aren't they together? Could there be a supernumerary? No. Could there be a lip habit? Well, maybe there is. You can see the vermilion border here and the changes. And that's exactly what this young lady's been doing and making a difference to her alignment and the changes to her lower lip architecture. Okay, so this has got to be a supernumerary perhaps here. Why is that tooth not erupted? No, there's nothing in the way. Yes, there is. Still has a finger habit. Okay. Well, this one is not erupted because, well, there's a supernumerary in the way this time. Erupted and perhaps attached to the back of that one, perhaps not, but certainly posing, if it's attached, a lot of significant treatment issues here about how to deal with that. And of course, when these teeth are, the midline's good, here lined up, and this one's off there, there's obviously a habit pushing that tooth aside. No, there's not. There's a very large dentigerous cyst around the cusp of the canine, and that's another reason. So there's always, fascinates me when the upper teeth don't align. What are the different reasons they don't? Now, infant mouths are another possibility that we get asked to see a lot, but we don't get a lot of seeing. And we get asked about bones, nodules, and are these really, are these teeth and so forth. We get asked to look at a little melanotic spots. Do they need to be removed? Are they potentially going to be become change and cause a problem? Or these epulides in newborns and neonates, do we need to do something about them? And the bottom line for us is always, can the parent feed? Are they getting in the way of bottle or breastfeeding? And to get a photographic record and monitor them and then decide at the appropriate time when removal is necessary or surgical intervention is required. But there's an awful lot of mainly epulides that turn up. But sometimes you get a surprise, and one from the palate a while back turned out to be a sequestrated myomeningeal, a bit of neural tissue in a small a small mass on the palate. The trauma to teeth, trauma to the tongue from natal or neonatal tooth can be quite significant and really interfere with feeding, and needs to be managed very carefully, with the feeding being the biggest issue, and whether that can be smoothed over or whether it needs to be removed. Each case will be different, but sometimes it can be quite significant, and a really very bad ulcer here. And the situations we've had where sometimes parents use a lot of non-steroidal anti-inflammatories, and the child bleeds a lot more than expected. And this is a young fellow that was thought to have either didn't feel pain, didn't interpret pain, or maybe had a temporal lobe epilepsy that was manifesting as he went to sleep. But he did have, it turned out, a nocturnal paroxysm. He'd be into sleep for about half an hour, and then he'd start biting his tongue. And it's in a similar group of conditions where people go walking at night time in their sleepwalking, or maybe bang their head in their sleep, and do other quite astounding things as part of these nocturnal paroxysms. And this is quite difficult to deal with, and often comes down to losing the teeth if we're going to stop this damage and bleeding that's happening. The primary immune deficiencies really important, and they turn up in infants in the mouth. And this is a Langerhans cell histiocytosis. The young lady presenting here, and this is her gum pad on the upper right. So be very in tune that the primary immune deficiencies manifest very early in Little East. And they can be a leukocyte adhesion defect. They can be any number of these neutrophil function defects presenting in the soft tissues. And a little bit later on is an example of another neutrophil function defect in an 8-year-old who's got just bleeding, excessive bleeding from gentle probing. And again, it shouldn't be like that. So really have your eyes open on gingival tissues. Cyclic neutropenia. Cyclic neutropenia, again, highlights the early loss of primary teeth and how important that is in assessing a child for a neutrophil function defects, unfortunately non-accidental trauma, and other conditions like this cyclic neutropenia where the teeth have been lost early, and hypophosphatasia is another example. And those gingiva really were that red. Every 21 days, the neutrophils would cycle, and he would get very red, inflamed gingival tissues. A little one who's lost their lower teeth, who has hypophosphatasia. Early loss of primary teeth is a really important thing to follow up on. Sometimes you get a surprise, and this is not just bad oral hygiene. This is an atriovenous malformation sitting under those D and the C, and the family presenting because of spontaneous bleeding and worried about what it was. So you don't see many of these, but when you see them, you don't want them to pass you by. Recently, a child turned up with a very typical background, unfortunately, of isolated family, 2 very special kids, both with autism, really poor diet, and this is an example of scurvy presenting in a child. We initially thought it might be a peripheral giant cell lesion here, but this young person had scurvy and responded, of course, to vitamin C. And is in the literature, there's many examples of this, of children who are isolated and poor diet presenting with scurvy. So it's something to tuck away, again, for your special needs kids to check their diets. Inflammatory bowel disease and orofacial granulomatosis showing up with the gingiva looking like this. Or it can be the folding in the buccal mucosa, again, of orofacial granulomatosis. These can often just present out of the blue and not be noticed for some time, but you need to involve your gastrointestinal team. This is the little pattern here in a younger person of lichen planus appearing in a 12-year-old, which is unusual, but there it is. And a leukoplakia in a post-oncology child that needs to be monitored. Dental caries can often be a sign of bringing someone in that has not had their dental work done. And this is a child with Prader-Willi syndrome and the salivary flow problems, and this is their first visit with the decay like that. And this young person had all major salivary glands missing. And I show this because I looked at this boy for some time and didn't appreciate it, that he was missing all major salivary glands and his salivary flow was poor, and his decay was related to that. And one of my colleagues at that time said, look, Richard, I don't think he's got any saliva. And the penny dropped. We were looking, but we weren't seeing. Nice and ropey, bubbly saliva. Notice that because it's always a problem. And when you have these very definite myelogenesis problems, remember the common associations with maybe renal problems and hearing problems. Gastric reflux in young boys often goes, young people often goes missed as asthma because the kids have a very definite cough in the morning and it's treated as a morning type cough with temperature changes and it's asthma. And you can see just how thin the teeth get and they present with these chipped edges. And this is asymptomatic gastroesophageal reflux. The beautiful dentition, 8-year-old. Here's the OPG. 12-and-a-half-year-old. Here's the OPG, and that's the reconstruction. When do you take an OPG to find those canines? I think you've got to set yourself some standards and say, if you can't palpate the canines buccally at the age 10, you need an OPG. You need to know where they are and avoid that very unfortunate situation. Non-accidental trauma, is that from palatal damage, force feeding or not? Need to follow through. This is Widmer ulcers, which I was not aware of till one of my colleagues had found these online and pointed them out. We thought it might be some example of bilateral trauma, but the BED, NAR, the Widmer ulcers associated with feeding and negative pressure on the palate. The child who's been punched, I mean, a good 30% of child abuse will have an orofacial manifestation. And of course, other child abuse examples of bruising on the arm and so on, that you may well get involved with your child at risk teams. And this is unfortunately an example of sexual abuse on a young boy that was from a male, an uncle, and it was noticed by a very observant young clinician, and they brought it to our attention, and we followed it through from there. A wart in the mouth. Why is that there? Was it on the fingers? Maybe it's on the tongue, but if there's not any other examples, how did that get there? Again, raises questions. And just finishing up with mental health is a very important part of what we do. And these are some examples recently about this, of our role in looking at not just the physical things we've talked about today, but the broader picture of our child in the context of their communities and with major depression and substance abuse. And I recommend those to you. Just quickly, 5 or 6 slides to go here. This is deliberate abuse, and kids can self-harm. They can do this sort of abuse. They can bite themselves, or they won't clean their mouth on one side. All part of mental health, anxiety issues. And of course, this young lady, she wouldn't open her mouth for almost 3 months, and was managed by my colleague to deal with that. And why is a long story. So thank you. I don't see Batman, of course. I see 2 upper teeth and 4 lower teeth. We've always got to be looking for the unusual. And this is the poem by Ralph Waldo Emerson, and he talks about to earn the appreciation of honest critics and to appreciate beauty, to leave the world a bit better, whether by a healthy child, a garden path, or a deemed social condition. To know that one life is breathed easier because we've done our job, we've looked after children well, that's to have succeeded. Thank you very much. I hope I'm just on time, Ari. Thank you.
Thank you very much. And I'd like to open up the question and answer session. The first question, Professor Widmer, was, is there any book relating to the conditions that you recommend?
So Ari, I didn't pick that up. Can you say that again?
The question is there a book relating to to your lecture relating to the conditions that you have presented? Look,
there's syndromes of the head and neck is probably the most significant one. That's I think it's in its 3rd edition. Correct me if I'm wrong there. Which has been a very important book. There are some others that I used to have about called the malformed infant and child, which may be out of print now. But certainly, I think syndromes of the head and neck and Smith's recognizable patterns of human malformation are 2 really useful books. But of course, there is so much online as well.
Thank you. Second question was how to differentiate between multiple uvula and bifurcated uvula.
The uvula, the important thing here is to always look at the uvula and assess the shapes that you see normally. Normally it's a teardrop shape. And when you see a bifid uvula, like I showed you, or a smaller malformed uvula, like a very small tail on a corgi dog or something, very short, stumpy uvula, and you might palpate for the mid-palatal notch, that's how you look. And the point of discrimination here is that it's not what you usually see, and that's what's tweaked your imagination. And then you might ask questions about feeding as a littlie. Was there fluid out the nose? And listen to the speech carefully. And is there a hypernasal aspect to the speech, and so forth. And that way you would discriminate and see if there was an issue with the soft palate or was it not. And then involve, you can do video fluoroscopy with the speech pathologist to assess the function of the soft palate.
Okay, and from a patient and parent management view, how about looking at the dentist's face and the parent's face?
Yeah.
Please comment.
I always remember as a dental student learning how to pick the shape of teeth for making full dentures. And there was lots of textbooks about taking the face and turning it upside down and looking for the shape of the teeth that you would put on the denture. Look, there's no doubt a family history is important here. And again, I was trying to say before, you need to step carefully and in discussing with families about their appearance. And no one wants to be judging someone else's appearance as pleasant or not pleasant, or attractive or not attractive. It's just a variation of human form, and doesn't have any meaning from the point of view of maybe identifying a hearing problem or something like that. And it's the way you have empathy and using words that are appropriate. And I've often found speech pathologists very helpful here for a child that I'm worried about is not really doing the right thing. Eye contact is poor, maybe some hand flapping, and they're not listening, and their attention is really poor, and they're fiddling. And I might ask the speech pathologist to run a ruler over them and give me a background on, are they age appropriate with their background? And the parents will often benefit from that and appreciate that someone's given them some ideas.
Okay, thank you. Professor Widmer will answer all the other questions that are in the question and answer box. I'd like to thank you, Professor Widmer, for your excellent lecture. The vast and huge amount of clinical cases and photographs presented reflect on your extensive and varied clinical experiences and knowledge, and we all thank you. And we look forward to seeing everybody at the next IAPD International Congress, where we can actually give ourselves a little cheer and hugs and see each other in person. Thank you, and enjoy the rest of the day.